Uh, so we will finish out the monitoring and hypoxemia with a few cases. So the first case is 61-year-old man underwent mitral valve repair and two-vessel CABG. This was complicated by RV perforation, which was repaired, and he was separated from bypass to central VA ECMO. You can see here the cannulas in the right atrium and the ascending aorta, and the chest was packed open. There was massive blood loss during the case, and he is coagulopathic in the ICU. The ECMO flow is 3.1 liters per minute, which is providing cardiac index about 1.6. You would like to increase the flow to decompress the RV because of the injury, but your ECMO specialist says it is not possible because of some issues. Discuss what these issues could be and what you would like to do next for this patient.
Do you have volume loss issue?
Yeah, volume loss issue, very good. Yeah, so massive hemorrhage during the case. Could have a low filling pressures, which may be inhibiting our ability to flow more on ECMO. Yeah, very good. So we could give blood, correct coagulopathy with product or crystalloid.
Switch to periphery.
Switch
Because it's
to
after 48 hours.
Yeah, so maybe you'll likely have to downsize your cannulas because these are central cannulas, which are usually bigger, and so you can flow higher on these types of cannulas. So that may inhibit your ability to provide more flow.
But after 48 hours,
Yeah, maybe.
Yes, with that being said, if you don't have the choice or you think the patient still coagulopathy, and sometimes they may not necessarily change right away. You may not be able to gain more with your peripheral VA than with your central VA.
Very good. So here, probably the most predominant problem is a low circulatory volume. So we'll want to repeat that to increase the flow.
Before we move on, sorry, when would you consider starting anticoagulation in this patient?
Oh, in this patient? Yeah, that's a good question. I think for this specific patient, with the information we have, I wouldn't be too aggressive at the beginning. Reason is we have open chest, we have central cannulas. The surgery he had is not very compelling reason for anticoagulation, so there's no high-risk mechanical valve or other condition. Those are the things that I would think about, and obviously the coagulopathy. Yeah, in our experience, a lot of post-cardiotomy ECMO with open chest, you can get away without anticoagulation for some time.
Even if you have normal thromboelastography or
Yeah, if you've resolved your coagulation, yeah, definitely, yeah.
would you then start it or?
Yeah, absolutely.
The VA ECMO, you can leave your circle for the anticoagulation for a very long time. VA ECMO, you want to avoid because you're injecting directly in the arterial system. But that being said, at this phase, it looks like the risks of bleeding outweigh the risk of thrombus. But I don't think there's a definite answer. It's when the surgeon
Yes.
when the surgeon says it's okay, you can just
Yeah, usually the surgeon wants to know.
and cautiously, you don't have to fully anticoagulate your patient, right? You could have a small dose of heparin, enough that your circuit is not going to thrombose, but then that's not going to get you to a therapeutic level. Like if you have, and there's some evidence actually that leaving the circuit without heparin at all will create some degree of coagulopathy in your membrane, and then it's a vicious cycle. Can be enough to avoid clogging of the membrane without causing the patient to bleed. So you could find this compromise to say I'm not fully anticoagulating the patient, but just enough so that I don't start that inflammation and coagulation and coagulopathy within the circuit. And then when the surgeon is happy, the doctor side, when the surgical team is happy, then you can switch to full anticoagulation.
It's a good way to show that there's ability to tolerate also, if you provide the one level at the beginning.
Is external pressure a concern here also? But the chest is open.
Usually not if you have an open chest, unless if there's packing, like if you have some packing, that could be an issue, but again, if the sternum is not approximated, even if you have packing, they tend to see that the does not generate that much pressure. Okay. Another case, we have a 22-year-old man with ventricular tachycardia after heart transplant, requires separation from bypass to peripheral VA ECMO through the right groin because of graft dysfunction. The chest was closed. In the ICU, the ECMO flow is 4.6, which is a cardiac index of 4.7. The fellow in the morning says that the delta P is 41 and recommends that we change the oxygenator. Discuss if you agree with this, and if not, discuss what other assessments you would like to do before coming to a decision. So we didn't talk a lot about changing out oxygenators, but it's not a benign thing to do. Here, if we're on VA ECMO, to exchange a component, you have to cut the component out. So all the cannulas stay, but you cut out the tubing with the pump and oxygenator. And so for that period of time that you're doing the exchange, you're off ECMO. So depending on the native cardiopulmonary status, this could mean you have cardiac arrest for 30, 45 seconds, depending on how good your staff are that do exchanges. So exchanging components is not something that is benign. So what do you agree? Yes, we should change the oxygenator, or do you think we need to do some further?
Is there any large visible mark?
Okay, if there's some visible clot. Okay.
We need more info, I think.
Yeah, I agree.
We need the trends you had mentioned.
Yeah.
The trend of the delta P is more important than the actual number, right?
Yeah.
And to determine what the hemoglobin is the patient overtransfused, are they polycythemic, triglyceride level, etc.
Yeah.
There are other things that are potentially reversible that can help change the delta P without us having to cut it out.
Mhm. Yeah, very good. Yeah, so the delta P could be high because of high flow. I think one of the most important questions here is what is the clinical endpoint? What is the tissue perfusion? Because the membrane is providing gas exchange. So is the organ perfusion satisfactory? Are there impairments in the arterial saturation and the tissue perfusion? Because if those are fine, we shouldn't chase the delta P, and that could be a reason to just let it go.
So a good approach is when you initially put your patient on ECMO, look at what the ratio of your delta P to your flow is, and follow that trend. Because the problem with the delta P is because it's flow dependent. If you have a patient that has flows of 5 liters and the delta P is 41, but then later on during the day, the flow is now 2 liters and the delta P is still 41, the delta P is not changed. So there's no change in the trend, but the ratio is significantly different. And that means that potentially your membrane is thrombosis. So to make sure that you follow not just the trend of the number, but also the flow. Because again, same flow, higher delta P, you have a problem. Same delta P, lower flows, you also have a problem. And then depending on how fast it starts to rise, you may have to change it even if the oxygenation is fine, because oxygenator failure is not always concomitant. You may have an oxygenator that is oxygenating perfectly, but then will thrombose in an hour. So you really want to look at those trends. So if you see that the ratio of flows to NTP is starting to change, you want to follow a little bit more closely to decide whether you change it electively or not. Because if it happens at 3 a.m., depending on the logistics in your hospital, you may not have the people to change it. But you also don't want to change a membrane that doesn't need to be changed, because again, more often than not, it's a situation of cardiac arrest, whether you're on VA or VV. Because if you're on VV and your patient depends completely on the ECMO, when you clean the circuit, they will arrest of hypoxia arrest. So just to keep in mind.
Okay. Next we have 52-year-old female with pulmonary fibrosis, has acute or chronic hypoxemic respiratory failure from exacerbation of the interstitial lung disease. She's placed on VV ECMO, the right femoral vein and right internal jugular as a bridge to lung transplantation. You wake the patient up. She's eating meals, participating in physical therapy. The arterial oxygen saturation remains persistently subsatisfactory despite a recent oxygenator exchange. Discuss what might be contributing to the situation and what other intervention you might consider.
When you say subsatisfactory, what is that?
I left
We're
it.
talking
I left it a
60,
little. I left it a little open.
60, 70?
A little open for discussion. So that's a good first question. What does low arterial saturation mean?
It depends, as pulmonary fibrosis patients are quite used to the 60s and 70s. At home, you find them on the classics and at home. So I think the best answer to any question is, it depends.
But realistically, what could be the reasons why the patient is hypoxemic?
ABC, okay, as troubleshooting, we mentioned ABC here.
Yeah.
We can apply all of them, ABC, okay, air, B, maybe she's a B, that's not written here, C, clots, or resupply.
But you also want to remember, you have, as Alia mentioned, there's a patient and there's a circuit. So it could be a circuit issue, it could be a patient issue, right? So if it's a circuit issue, you mentioned thrombosis, air, you would probably see it or hear it. It could be that your membrane is failing, it could be recirculation. Patient, maybe she has a worsening of her interstitial lung disease, maybe she has a pneumothorax, who knows? But that being said, she's eating meals and participating in physical therapy.
Yeah.
I almost want to say it doesn't really matter the saturation of this patient. If she's capable of eating and participating in physical therapy, she's getting enough oxygen for what she needs. So I think it's, as she says, it depends, but in that case, I would probably just change the alarm of the saturation of the
Exactly.
body.
This is what I would
Start
agree.
talking.
Sometimes we focus too much on the numbers and the saturation is 85, it's always 85, and these patients, they do not need 100% O2 saturation. And so this is a good example where you just leave it alone, there's no issue, and let it go.
And sometimes we do take central venous saturation, see the lactate, see the central venous saturation.
You always,
Happy, satisfied, and she's the
you
patient.
always want to check that you've ruled out all the other reasons why potentially there's a problem. The membrane was just changed, so presumably it's working. We're assuming there's no thrombus. We are looking at recirculation, and then we're looking at the patient. If all of those are okay and the patient is otherwise fine, the level of oxygenation actually doesn't matter. She will be able to do physical therapy if she has titular hypoxia. At the end of the day, I think that's sometimes we're trying to do too much, to just have a good saturation. But there are signs here that she's receiving enough oxygen, at least her tissues are receiving enough oxygen.
I think that, yeah, that's it. So I think,
Yes, that's my advice.
Any questions while we're transitioning?
Did you guys get coffee?
Yes, we do.
So we can finish in 10 minutes, we can finish in 5-6 hours, according to how interactive we are, because I will not answer my own questions. Because that's beating the reason of why we're here, right? I will be talking to myself, and I hope the coffee has woken everybody up. Okay. Right. So, do you guys have any questions so far? Anything? Or everything is clear? Are we going slow or are we going too fast? Okay. So, you still remember this? So we'll start with the cases. I only have cases. Few description in between, but mainly the cases are for the. So we have a 55-year-old female requiring a VV ECMO for ARDS. So initial setup was challenging because of difficult venous access. I understand also here the cannulation is mainly intensivist based, yes?
Yes.
Okay. So as you know, either you get it the first time or you struggle. It's one of either. So either your life is too difficult or too quick and too fast. So these people, they had difficulty with the cannulation, and in the initial flow was only 3 liters, which wasn't very good at the time, but they were okay with it. Let's deal with it in the morning attitude, which you should not do that, because eventually you will hit even stronger. So second day, the flow even dropped to 2 liters. Okay, and oxygenation worsens. So this is VV ECMO, and as we said, this is respiratory support. So if it's not flowing, that means saturation will drop. Despite increasing ventilatory support, which is, do you think this is a wise step or unwise? Unwise. So that's the whole point, right? Okay. So in general, when we approach such cases, first we have to think what's going on. You only think what's going on if the patient is giving you time to think. If the patient is arresting, then increasing the ventilation and bagging and whatever might feel okay until someone troubleshoots the external circuit of ECMO and the patient, okay, to know what's going on. And while you're doing this, you have to do the clinical assessment and thinking what is your next step. So as we're talking about flow, I will concentrate about flow because it's very important concept. ECMO only works when it's flowing, just like your hemodynamic. When the heart arrests and there is no flow, you're dead, right? And that was the change of concept from what is, as we are discussing and debating what is the right saturation, a similar discussion and debate comes to that, what is the appropriate perfusing pressure, what is the appropriate MAP? Should we set up to 65, or is 55 enough, or is it 85, right? But again, it's not the pressure, it is the flow. So flow, so as physicians, I see you're mostly anesthesia also, right? Okay, so this is a common question in your exam. So it tells you that to have a flow, it depends on the diameter of your tube. So either the diameter of the cross section of the hemodynamic blood vessels or the ECMO tubing, mainly the draining tube. So if you put a small tube, you will have a poor flow. This is very important. And then that's the radius and also the
Yes.
link. The link might not affect much unless if it is a small radius tube, because if you put a 21 drainage cannula that is 38 centimeter, you will drain differently from a 76 centimeter 21 cannula. The same radius, but because of the length. Okay? And that's very common. And then viscosity we know, and the resistance to flow, which is that when you are returning, what is the resistance to that flow? It's in the case of veno-arterial ECMO in particular. Yes, and that's on the VA when you go back to that. Okay, so this is especially for nurses when they come in the morning for an ECMO patient, they lose their mind. Because it's exactly like Patrick said, it's a full room of so many things, and moving stuff is problematic. So especially if you have also a CRRT and nitrate, and so you have to untangle this patient. And remember, you have two circuits. Just think of an ECMO patient as circuits. So the hemodynamic circuit, patient ECMO circuit, ECMO oxygen to the wall circuit, because sometimes it is closed. So one time we have to troubleshoot that the oxygen from the room was disconnected. Okay, so, and then the ventilator circuit, the CRRT circuit. Think of circuits physiology or concept. Okay, and as we see here, we measure the pressures in 3 places. Pressures are very important. I used to think it's not important. But it is important if you want your team to understand what you say. Okay, so it is easy not to have an ECMO protocol if you are there all the time, because then you can play the it depends all the time. Oh, I will tailor, I will have personalized approach and so forth. But when you go home, people will not continue what you're doing. So when I was an ECMO physician, I felt playing with ECMO is fun. When I became a leader, I noticed that you have to build some kind of a system from minimum what is there. And it's very easy when you put the pressure, because in your troubleshooting for the team, the ECMO specialist, the nurse, the resident at night, he will understand what you are explaining in the air by numbers. So if P1 increased by this, then do that. If this is so, it becomes more understandable. So the pressures we have here, if you can see, P1, P2, P3. So P1 is the suction pressure. And that should be negative or positive? Negative. So that's P1. P2, so that is pre-pump, right? P2 is here. You can see this is the pressure transducers. Okay? So then this pressure represents, it should be positive, right? Because it is after the pump, and the pump is pushing. Pre-membrane, right? So this pre-membrane is where I will get the pre-membrane oxygen sample. And the P3 is post-membrane. So this should be negative, right? If it is positive, what does it mean? Okay, which happens when you put them upside down. Or, no, when it is positive. That means you're sucking, and then positive, positive, positive. That means the blood is going that way. Do you insert ECMO cannulas?
Yes.
Let's cannulate a VV ECMO. And the first, you start running, and P1 is positive. Other than losing your consciousness.
There might be a clot in the system. Yeah.
So the blood is pushed from the patient to the pump.
Yes.
That's why it's positive. When does the blood push from the patient? If you are an arterial candidate, yes. So insertion in an artery gives you that. So what? I don't know if you understood that. It's a problem, right? So that's what it means when the P1 is positive. You should know that. Because if this happens, you're like, but first, you ask her, any perfusion here? Good. First I ask perfusion, did you zero the pressures? Because very often, they prime very quickly, especially in ECPR or whatever, and they don't zero the pressures. Then the pressures means nothing. After connection, they clamp, 0, 0, 0, then it becomes something. Okay? This is a closed system pressure, not like the old one. The old machine used to be open. 0 and level and crap. But no, this is automated. So it should not be positive. P1 should not be positive. Make sense? So now we just forget P1. Okay, then P2. Is P2 important? So this would be the most positive. So out of these three, which is the highest number? P2. Because while going through the membrane, you lose some of your pressure with the resistance of the membrane. So you become less. P3 is less, right? That's why the P2 minus 3 is positive. 48, for example. Okay, so minus 26, 127 P2, 127, 175 P2, 127 P3. So if the drainage is blocked because of the bed is next to the patient or what so, it is minus 130. Do you hear? Okay. What is this? This is very, very important sound. What is this?
Air.
Air. This is air. What do we do? Okay, it depends on how much air is there. But it is in V8 it's an emergency because it goes to the brain. So the first thing is the drop to the brain and then clamp and whatever.
So can I ask, how does the air come in when you do,
Because this is open. It should not come. But this is open. Because you see here, the bubbles are, so this a contaminated flow. But in real life, it shouldn't. However, we have seen a patient on CardioHelp, if you put the air bubble on, the machine protects the patient by turning off. That's how it understands. So one time we had a patient being moved and the sutures was not very good. Tiny bubble came in and this stopped patient arrest. That's why we changed our protocol into turning it off. But we trained our team what to do with it. But this because of so if I drop here, it should go. Because the fluid is contaminated, it should never happen. So see now, the air should not go. See? It's not as much. But because of the air contamination. So we understand the piece? Okay. Cannula site, very important. Super important. So we had a patient, I will tell you some of our patients so you guys can connect in the memory, don't go home and forget. So we had our patient sitting for months of VVA ECMO on Avalon, waiting for a long time. So in retrospect, when we went back, we saw on the X-ray that the cannula was moving up for the last 3 days. So she was sitting, playing on her bike, and then splash of blood. Okay, so immediately, she knew what to do, so she held and she closed. But you have to be very careful because the blood is very quick on this. And it depends which cannula comes out. So always check the level, the suture. It must be sutured on 3 sides. And when you clean it with, so do you guys clean it? Especially for nurses, it's very important. No, it should be non-alcohol based solution, no chlorhexidine. If you use chlorhexidine very often, the plastic will dissolve and it will crack. And if the venous is cracking, air will go into the system because it's a sucking. If the arterial, you will bleed. So you use povidone, I think. We should use povidone. Okay. So our patient, so the approach was they checked the saturation and they found that the saturation was low. They looked at her X-ray. Why do you need to look at X-ray for FEM, IJ, ECMO configuration? What would the X-ray gives you? Why do you care about the position?
See the difference.
Okay, so if they are 10 centimeters close to each other, then your recirculation chances increases. But if the flow or the suction is not that strong, you will not have recirculation.
So the more I read about it, I think it really again depends on where within. So the drainage cannula, there are multiple holes, right? It really depends depends on where is the
And
biggest
how-
amount
yeah.
of drainage.
And how much you
If
suck
there's, if there's no clot in your drainage, it actually comes from the one that is
from the
closest to
sides.
the pump. So the distance between the two cannula doesn't matter as much. At low flows, it does matter, but as soon as there's very high flows, there's so much turbulence anyway, that it doesn't matter that much. We actually put our cannula now, the drainage cannula, even on VV, up
Right,
to the
okay.
SVCR junction. Some centers, they even overlap their
Yes, yes.
cannulas, so that if you have the returning flow on the side rather than directly in front of the tip of the drainage, you don't have that much recirculation.
Yes.
And I've asked the people who came up with the 10, 15 centimeters.
That's why I don't use 15, I use 10. But why do I use it? Again, just to go home and that people will not bother me. So as I said, when you're working alone, you're the king or queen of self. But if you're working with others, so exactly what Islam said, with the suction, if you have multiple holes, your strength of suction will be from the closest holes. And if you are exactly like this, but the flow, the drainage is not from here, you're fine. But as you increase, you might get it. But we actually do the x-rays because what happened is that more than the recirculation business is the migration. So we do it for both. What Giselle is describing is a 76 centimeter cannula, which is, we call it bicable. You have drainage here, nothing here, and then drainage here. That's what they use on the PA or the bypass, minimally invasive. And then you put the cannula return there. So as long as you're okay, but I have seen, especially with short people, that the IJ cannula goes from the SVC, right atrium, IVC, because the patient is quite choked. Okay, that might be a problem if it is affecting your flows. Okay, or your oxygenation. So here this is fine, but here, do you see where is it? Is this optimal? Okay, let's keep going in the case and then we'll see if this is optimal or not. Okay. So this is the algorithm I usually teach on. Because on VV ECMO, the most important thing is oxygenation, right? And when the oxygenation goes south, there are so many things that could happen, and especially if the patient is arresting or desatting or whatnot, you have to make sure that you are organized in an organized manner so you finish quickly. And you allocate your team. For example, if the patient crashed, RT knows he will up the vent, nurse knows she will examine the patient's ticket, and the ECMO specialist knows he will get the ECMO. There is no running around. Everybody knows what to do. And then if the saturation drops here, first thing we have to know, did the ECMO flow drop or not? That's the most important thing. So how much flow is enough? So is 3 liter enough? Is 5 liter enough? Is 8 liter enough? So it depends on something. It depends on what? Excellent. So relationship of ECMO flow to cardiac output flow should be less. It should be at least how much? 60%. So since we're talking about this, because this is quite important. This is super important. Saturation depends on, so in general, in me and you, it depends on the oxygen content in a liter of blood times cardiac output. Yes? But now you have another output, which is the ECMO output. So the ECMO output compared to the cardiac output should be minimum of 60%. So if my cardiac output is 6 liters, at least you have to give me 3.6. Okay? If the cardiac output is too high because I have fever, or because I'm septic, or because I'm awake and fighting, that's why you drop the cardiac output, to maintain that percentage. And that is in non-contributing lung. If we assume that the lung has zero contribution, of course, as the lung starts improving, the saturation will start improving, even if everything else is the same. Okay? So that's how to determine oxygen saturation on air. Okay. Okay. Make sense? So this is our patient, and we were discussing the location, right? Only if they are kissing, that's when you have a problem. But if you bypass, you're fine. Okay? And also here in fem. Again, if they are, so there is a femoral cannula, the return one. That means the cannula has to be open only here, right? And the drainage has to be open all over. If this and this are close to each other in a tight place of the IVC, you have a problem. The older cannulas, there was a 10 centimeter of plastic that they don't produce that anymore. It makes the recirculation even worse. So that's why in the fem we have to be careful. Okay, so say that the adequate blood flow. Okay, so blood flow has not changed. Trends are also very important. Blood flow is 4 liters. Patient cardiac output hasn't changed. Everything is fine. So the question is, do you really need to improve the saturation, exactly like the case Patrick described? Or do you have what? Recirculation. That means the ECMO is flowing nicely, heart is flowing nicely, but someone is stealing from the other. Okay? I used to give an example of a supermarket where I give money, my husband takes the money from the kid, then I take money from my husband again, then I give it to my kid goes to the supermarket, gets intersected by my husband, he takes the money, so the money never reaches the supermarket.
And then your mother-in-law comes.
My mother-in-law comes too. Exactly. So that means you're just, that the ECMO gives you the red blood, takes it back, takes it back, and you never enjoy it. But it's flowing beautifully. And you're flowing nicely also as a patient. But the interaction is not appropriate. So this is where you think of recirculation. Don't think of recirculation when your flow is dropped to half. Right? And that's my point of arranging the stream of flow. Right. If you have a low blood flow, that's when you start thinking. And that is the topic we're talking today. So if we have low flow, what is the most important thing that affects your flow in ECMO is? The suction, yes? The venous cannula, the drainage cannula. Am I draining or not draining? So the question is it not willing to suck or it cannot suck blood? Which one is it? Okay? So if it cannot, that means what? If I'm trying, but I cannot get anything. Either you include it, either outside because it is kinked, or inside because you're clotting, for example. What else? Maybe. Which could be our patient. So there are some case reports of perforated cannulas into the retroperitoneum. And from the beginning, the flows are bad because they contain hematoma that still flow 1 to 0.5 or so or 2. We can send you some of these case reports. Okay? So I cannot suck because I am occluded. Maybe there is no blood to suck as well. Maybe there is no blood. Why I cannot get blood? Maybe because bleeding, or there is bleeding, no bleeding, and the cannulas are fine, but the blood is not coming out of the patient. Okay, so dry because they bled, either bleeding inside or outside. Why do I do an abdominal X-ray to see where is my cannula position? Because a cannula that is low and then patient is constipated or abdominal bleeding or whatever. So we had a cesarean patient where we delivered her on ECMO, pulmonary hypertension. Then she bled in the abdomen. Nobody knew she bled. And because she just bled now, the hemoglobin hasn't dropped. Okay, but when we did the ultrasound, we found huge hematomas and the IVC is collapsed. So initially, just until we get flow, because that was VA, we pushed the cannula to the right atrium to get some blood to save her, but then we looked around. So this is number one. Okay? Displaced cannula, inadequate cannula size, hypovolemia, abdominal compartment, and so forth. Okay? So this is a flow perfusion. Mechanical problem, inadequate drainage. That's it. If the flow is fine, then you think of, I'm flowing, but I'm not functioning. That is because of recirculation, or the oxygen from the wall is not nice, the membrane is failing, and everything else. Okay? But first, is it a low flow problem or a usual flow problem? Is this useful? So this is the drainage insufficiency. The patient, the ECMO cannot suck blood from the patient, either because the way is occluded, or there is no blood to be sucked, or there is obstruction. Okay, so that's why you have to examine patient top to toe. Do a blood gas. So that's why when I see the flow is 1 liter, and I don't understand my fellow orders a pre and a post oxygenator gas. That I don't understand. Because your flow was 4, now your flow is 1. Whatever is the oxygenator function, you will not be oxygenated well as a patient. Right? And that's why I try to link first this A and B line. Flow good or flow is bad. Okay. Just very quickly for the pathophysiology. Why do we say 60%? Because of this. Okay? So the venous return, the cardiac output is 6 liters. That will divide into the ECMO, and that goes still due to the heart. Okay? If this is less than 60%, and this is more than 40%, saying that we don't know the lung function, because maybe the lung doesn't make anything red, okay? Then you have a problem with this color, okay? Okay. This is clear? Okay, this we did. So now we know the patient has a problem with low flow, right? And there is no mechanical obstruction. We found the negative pressure more than -100, so more negative than -100, -120 and so forth. And the patient had significant bleeding from the day before. Okay? However, it is very important to check cannula position, if you can do it with a Doppler, to see the flow, the laminar flow. One patient we did, but it wasn't a VV, it was a VA. We put the ECMO. 30 minutes later, the thing stops. What happened? Patient had PE. There's still clots in the IVC. The cannula tried sucking, and it occluded. So what we did is we exchanged the whole thing. So always think of that. However, in our protocol, if the patient has negative pressure more than -60, give volume. The nurse has that as a standing order. Okay. So the conservative management is, first of all, you have to restore flow. So you examine the patient circuit, you give them volume, and you figure out why you're not flowing. Is it obstructive inside the patient, or in the cannulas and the tubing, or is it something inside? Okay?
What was step 3? Diagnostic course.
Diagnostic workup, yes. And this is what I'm saying. If the patient is giving you time to do this, well and good. If not, then you have to manage sustaining patient life while you're troubleshooting. Okay? Low flow, negative pressure on P1, give volume, volume, volume until you figure out what. I thought I wrote here the sizes of the cannula.
Yeah,
I did? Okay.
Yeah.
So what turns out to be that this is a patient who's tall, and whoever yesterday was fighting to put the cannula in, he put a 38 centimeter cannula. You have to put, or you have to make sure at least, you are in the hepatic IVC. At least. Because that's the only IVC in the abdomen that is stented by the liver. The rest is a collapsed IVC, right? If you have abdominal compartment, it'll affect that. So you have to at least go there. If you can go higher, no, why not? Mind you, as the lung condition changes, the relationship of things changes. So if the lungs start recovering and expand, what is that thing? The diaphragm will be pushed down. The other way around, if the lung gets worse, you go up. And again, if you're doing physiotherapy, this can move. Okay? Yes. But the diameters are fine. 25 and 21 is fine. Okay? Any question? We go to the second.
Do you have a guideline for the length of the cannula that you should use per size, for the height of the individual?
No, but what there is you have to know how much flow you might need. And then there is perfusion notice. There is in
Body surface area chart.
yeah, but that's for VA mainly. But there is for the, and I can show you at the end. If you have the catalog for your cannulas, they tell you the size and the length, how much flow you can get at this pressure arterial, this pressure venous. Okay? So I know that at 21 venous will never give me flow more than 3. Okay, so if I have someone who is tall and big and septic, remember sepsis can even double your cardiac output. That means your ECMO flow has to change accordingly. Okay? And what Jazan was saying is very important, especially in VA, which is more and more people are tending to forget. So if you look at me, my oxygen extraction from my upper body is higher than from my lower body, right? So if you leave the SVC and you don't drain the blood, the venous blood from the SVC, right? Because this is, my cannula is in the IVC, I'm sucking, right? This blood that bypasses ECMO goes immediately to the right atrium is whatever I don't drain in the IVC, because I can never drain 100%, plus the upper body, right? So especially now on VA, what they do, this cannula, they push it up to the SVC. And then you have holes on the side, you can suction. But in the bicaval cannula, in the middle, it is muted. There is no openings that you might clot there if you have low flow. Because if you're weaning VA and you go to a flow of 1.5, and then maybe if this is an RV problem or so and you want to do an 800 flow, then you will have to up if you stay on it for a long time. Okay, second case, how is my phone? Okay. So we will not take long. So 40-year-old cardiac surgery on central VA ECMO, developed sudden hypotension and low cardiac output. Sorry, low ECMO. Post-sternotomy patient, ECMO flowing badly. Number one reason is with a wide mediastinum. No, you bleed in your pericardium. Okay? The right atrium is the most posterior. And it can collapse very quickly, and then you don't have enough blood. Okay? So the same thing. So don't be alone. Don't be alone. And if you have a team, divide. RT does this, ECMO specialist does this, nursing does this, physician does this. Just like on a call. As a physician, you should not be doing much. Because if you're doing something, you will not see the rest. Okay, last case. This is very common, and in Saudi now we see a lot of influenza B and influenza A. Despite we are running very strong vaccination campaigns. So this is a 35-year-old who got VA ECMO for myocarditis mainly. So the blood pressure was down, ejection fraction 50%. Today is day 5. Okay, on the monitor, blood pressure is 98/70, heart rate 105, pulse ox 191. No inotropes. This is very important. Okay, on a VA ECMO, to know the blood pressure, I need to know three things. What is your ECMO flow? What is the patient blood pressure and pulse pressure? But what is your inotrope / vasodilator? So many people use, for example, nitroglycerin. I use a lot of nitroglycerin. Do you use it on ECMO?
They like nitroprusside better.
Yeah, good.
Same,
My
same.
people are so afraid of nitroprusside. Especially if you have a waking patient or even you extubate them, you find that, especially the elder people, their vasoconstriction or vascular tone is stronger, and the blood pressure rises, and you drop the ECMO flow, and the blood is not flowing, and they go low perfusion. So sometimes you need to vasodilate so the ECMO can flow and the heart can pump. Okay, so this page, anything you notice here? Is this good, bad, high, or low?
Not good.
Not good. Why?
Pulse pressure is increased.
So pulse pressure is 70, 80, 90, 98. 28, the pulse pressure. Okay. I agree, the number is not good, but why? How is the mass?
High.
MAP is very high.
Yeah. Your afterload is increased.
MAP is very high and harming who?
Myocardium.
Exactly, the heart. Not the ECMO, the ECMO is slow, but the heart is not liking this number. That's very important. Especially with this pulse pressure of 28, it tells you that the heart is trying to
Compensate.
pump, okay? And that's it's very common scenario. You see the pulse pressure increasing, blood pressure improve, the patient's MAP is 100 for a day or a few hours, and then everything goes back. And you think, what happened? What happened is, the pressure was too high for the heart, it's trying to recover, it decompensates again, and that prolongs recovery. Okay, ECMO flow 3.9, also what do you notice here?
Actually, can I ask if you don't mind?
Yes.
So in this particular scenario, what map would you aim for?
And this is what I'm trying to say. So the MAP, I want the lowest perfusing MAP. Agree? If I can perfuse on 55, I will go. I will look at my SpO2, which is the pre-pump or whatever you want to call it, and I will look at the lactate, I will look at the level of consciousness. If the MAP is 55 and patient is fine, I will go for that. Because the lower the MAP, everybody can flow. The heart can flow and the ECMO can flow.
In your SpO2, you take from where, sorry?
SpO2 you can take from the central line, okay, or of the pre-membrane is SpO2 also, because it's pure shunting.
So if your SpO2 is, say, 65 and above,
That means
that rate is okay.
your perfusing.
Then you go to the lowest map that can achieve that
Yes.
level.
You are really risky.
And
Yeah.
that's where you start the nitroprusside.
Yes,
or the
yes, yes.
nitroglycerin.
Yeah. That's what happened. I start nitroglycerin today. The fellow stops it in the evening because he didn't see others do it. Once we get into that, then I'll do the nitroprusside.
What about kidney function here and urine output? Does that factor in?
See, I'll tell you. I wish we had cannulas. The cannula, the arterial cannula is around 38 centimeters. That has maybe 6 or 7 outside. So the cannula, if it's inserted here, it will reach. And then pushing from a single hole or 2 or 3 holes. That means the flow is so much higher than if you have muscle learning, right? What is the first organ comes? Kidney. Kidney is the least
Forward.
of all organs. If not hit before. Not hit before. It will see beautifully. What is your worry is what I'll show you now. So just keep on that. I'll show you by the photos. What else you notice here? ECMO flow is low, high, good? High. Why is the ECMO flow high? You didn't ask me about the BSA, how big the patient, how low the patient. Did I calculate right or do I calculate wrong? But you said high. Why? Because of relax. That means I'm flowing higher than needed, right? So before I start vasodilator, the first thing I will do is decrease the VA ECMO flow. Okay? And then the heart will pump more. But that's only looking at the blood pressure. But we're not looking at the whole patient yet, because we will see now. Mechanical ventilation, pressure control of 10, PEEP of 10, RR of 10, and this is the ABG. Okay. Anything in the ABG? I feel like I'm looking at this for the first time. Anything wrong with the ABG? Very good. So oxygen hemoglobin, which is what is important, is low from there. So I already took one step for you, and I told you where the arterial line is. It's very important to know where the arterial line is. Okay, what else? CO2 showing. Okay. So what's going on? So many data, but what's happening? Because you cannot treat what you don't see.
What I understand is with the maximum FiO2, still we are not able to perfuse in ventilating.
Perfuse or oxygen?
Oxygenation.
How do you judge? So you remember the equation I told you about VV ECMO oxygen saturation? And VA is different, because the physiology is different. So the final auto saturation here depends on what? On VV ECMO, we said the ratio of ECMO to cardiac output flow. On VA, that's why I asked you, is the problem with perfusion or oxygenation? Because eventually, oxygenation of the blood is how much the oxygenation of the liter of blood, not the flow, the cardiac output or ECMO, whatever, right? So what is the problem? But you're right. Looking at all of this, I have a patient on a VA, so that's why if you have so much data and you don't know what's the problem, and this is real life, I didn't put one single problem. The trick in ECMO is to identify the problem. Once you identify the problem, you will move in the chapter of the name of the problem and you will go. Okay? So what is the problem here? That's the question. Or there is no problem.
Maybe some problem with the lungs?
No, what is the problem? What are the things that are wrong with this patient? Not the reason. So the saturation is low, the ECMO flow is a little bit high, and the achieved MAP is a little bit high. Okay? So what we did is we dropped the ECMO flow because we have a clear order MAP never more than 70, 75. So they dropped the ECMO flow. What to 3 point something, and what happened with the saturation? It dropped. So they put it back at the coders. So what information you got from what I said? Or we move?
As the heart is struggling and it's working, it's trying to recover, and we are on a high ECMO flow. Maybe the lungs are poor and some sort of mixing in the upper body, and the right side is getting less, just like in Harlequin syndrome.
Maybe. So how do we judge? Why does increasing the ECMO flow worsen saturation?
We should have both of limb saturation. We should have both of these.
Okay, very good. Right. So remember what we said here is you have patient circulation. This is the best slide to show you that there are two circulation happening and two sets of color change. Blue to red, going to the right to the artery, right femoral artery, and here blue to red. Right? Okay. So the more I suck from the blood in VA, the less the heart will find to pump. There's no venous return to pump. That's why we should never go 100% cardiac output with our calculation you made. Because if I suck all the blood, the lungs will clot because there's no blood flowing there, right? So I have to keep something flowing. Okay, so that means so many colors So the right hand saturation alone is not enough. I have to check here, 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 and lower leg. Kind of map where the problem is. If all are low, that's different from if some is low, some is not low. Okay? Okay. So just, is this useful or I can skip it if you know it already? So this is the physiology of peripheral VA ECMO. IVC, they're sucking blood, pump it to the oxygenator, you go to the femoral artery, right? Right. Femoral artery goes to the aorta in in an opposite direction, then goes to the tissue. This is the undrained blood. Okay, this is very important. The undrained blood, according to the lung function, will change color. If the lung is not working, this will stay blue. Like our patient, she has influenza B. She has influenza A, myocarditis, but she has also ARDS. So this is very blue. Okay? If this is working beautifully, this will be red. And then this will mix. So it's affected according to the lung function. In central ECMO, we don't have any of this. You just go down. Okay, so they did. So this is number one approach for hypoxemia on VA. You check all the saturation in the body, and then you go check the membrane. Okay? Because we said flow is not low. If the flow is low, we check why the ECMO not flowing, and we go through all of that. So we did the oxygenator, and the PO2 was 200 post-membrane, so the oxygenator is fine. And increasing the ECMO, again, you drop the blood pressure, you drop the pulse pressure. Remember, the pulse pressure was 28. It dropped because the heart has no venous return to pump. But this didn't work for us. So, yes. So this is the Harlequin syndrome that they don't call it that anymore. Suzanne told me. So this is the link to the paper, to the new nomenclature they have. Thank you to them for that. I put it here. So what happened is, remember we said, if the heart is not functioning, the blood ejected from the femoral cannula will be too strong and going up the arch and then going up to here. Okay? But we have to remember that the first branch of the aorta is not the innominate and the radial artery in consequence. It's actually the coronaries. So if the lung is so bad, okay, that means blue blood is going to the coronary, and the coronary will not recover. That's why the resting lung, I thought you guys would point to that when I put it in the case. The resting lung parameters is on VV, not VA. Okay? You have to give the coronaries red blood, not blue. So as the heart starts pumping stronger, it will pump this white until here, and the ECMO will pump until here, and according to who's stronger, just like two kids yelling, who's louder, that will depend where that cloud will move. So as the heart starts recovering, the cloud is here, then it's coming like that. I have seen a patient where we had reverse ECMO flow, if the machine allows it. Okay? That means the arterial pressure is too high, that instead of the blood moving this way from ECMO, it's bleeding into ECMO. Okay? And this is actually one of the ways we test weaning on VA sometimes. Okay. Yes, so you measure what the native lung is giving you at the mixing point. As we said, we have seen mixing point where your right hand and right ear saturation is 85, left ear, because the left left carotid saturation is 98. Okay, and that's why the kidney never suffer, because the first one getting a very good oxygenated kidney. Okay, so this is the approach. What is the lung doing? What is the right upper extremity saturation and the membrane function? Okay, if the membrane is not functioning, then خلاص, the solution is there. Membrane is not functioning, fix it. If the membrane is functioning very well, and you start seeing this blue moving, fading from here, where the red is fading from there, That is the dual circulation syndrome. Okay? And there is a good paper in critical care about this. Harlequin was, I think, disrespectful to someone, so they were thinking to change that name. Until they gave that paper of changing to dual circulation, someone was calling it differential exchange, gas exchange, and other things. And again, you think of the saturation, upper to lower or right to left, and the geography, it is different. Okay? And the gas membrane. Okay? And then you play that. Also, the CO2 is involved. So I have to finish and go to the okay, 2 slides. So what should we do for this patient? So we just agreed that the heart is recovering while the lung is not. So the mixture of the blue with the red is giving us a bluer burgundy than a brighter red, right? So what should we do?
To switch to VP.
Which is not ready yet to come off VA. If we can get off of VA, so, but if we can't, then what do? This depends on this, right? If I can make this red, how can I make this red? How? By putting a venous limb. Yes. So we're draining here, coming femoral artery, and we can come also to here. I make this red. So V, A, V. Okay? If I could change it from VA to VV, very good. If I could remove this femoral arterial cannula and go here, in the subclavian, for example, change configuration or even open and make central, that's good. Okay? But first put the lung setting appropriately, because many times, especially with pulmonary edema, you will find that with the resting setting, you're not even inflating the lung. If you put them 15, 12 or 15, 10, the lung open and then you're fine. Okay? But pulmonary edema is not like ARDS. Right, I have also, yes. So that's what we did. So with the return, some went to the femoral artery and some went to the jugular vein, but you have to be careful because you're draining 4 liters, and when the blood goes back to the patient, the afterload or the resistance in the venous is lower than the arterial. So the blood tends to go more to the venous. And I can fix this and control how the blood divides in the Y by putting okay? Yeah. So we've been using partial clamps, and then one of our colleagues said if you go to Amazon, you find it. So all of us over there. Okay, that's all I have. I hope I'm not late in time. Any questions? I should have 55 minutes. Was it useful? Did anyone sleep? Did I answer your question, the one I told you to hold on to?
So, we're going to have a wrap-up case. We have a 48-year-old gentleman who's been referred from another hospital. He has no past medical history. Presents in cardiogenic shock. He's on epinephrine 0.5 mg per kilo per minute. He's on vasopressin 4 units per hour. He's being given fluid bolus but with no adequate response. He's being intubated. He's on disease control, pressure control of 12. PEEP is at 10. Vital volumes are 6 cc's per kilo predicted by the weight. The PaO2 to FiO2 ratio is 120. He's on urine. Creatinine is 250. AST 540, ALT 319. The central venous saturation is 45. and the lactate is 7. It was 3 on presentation. Someone did an echo, and that's what it is. You may not be familiar, but this is a TE. This is the right ventricle, right atrium, left ventricle. Left ventricle, left atrium, left ventricle, aorta, and this is the left ventricle. It almost doesn't matter, because nothing's moving, so.
Yeah, there is very irritating smoke.
Yes. And then they did some fancy measurements to estimate his cardiac output, and the velocity time to grow is 6. Should be 20 centimeters. So we decided to put this patient on the VA. Any disagreements? No? Okay, good. Because otherwise I would have had to say. So we put him on ECMO. We do that under echo guidance to avoid this kind of complication. This is not this patient, but this is a patient that was put on ECMO without guidance, and as you can see, had a peripheral effusion. So we did that on under TE guidance, and in those cases, we really want to make sure that we see the wires at any given time. So you see the venous wire here in the IEC, and goes all the way up to the SVC because we're trying to put this cannula as high as possible, as Anya mentioned before. And we always check that in the aorta, you also see your wire before you start dilating to make sure that you're in the appropriate vessel. So there we are advancing the cannula. You can see the wire and the cannula that is being advanced, and we're going to stop just while we're in the SVCR equation. So, successful cannulation, no issues. Patient has a 19 French return cannula with a distal perfusion cannula in the right femoral and a 25 French left femoral venous drainage. Is now on pressure support 10/10, the rest rate is 28, tidal ones are 5 cc per kilo, predicted value 8. EFIO2 was initially 0.3, it's now 0.8. And the ECMO flows are 4.5 with RPMs of 2800, LTP is 24, FDO2 is 1, and the sweet gas is 2 liters per minute. Then the nurse calls you because we have these issues. The flow are no longer 4.5, they're just going up and down. So what is it then? I think I heard someone say chattering. So what does that mean? And what are your, how do you work out this situation? What are the first things you want to do? And what are your working diagnoses?
Asking to reduce the flow and see if there is jackling or not.
Say that again.
First go with the 4.5 flow and the P1 is like -100 and more. We have to first do it better with this section just to reduce the total flow like 4 liter, 300, and still P1 is high something different. And still P1 is like to go down again, so maybe this.
So you're talking about the venous drainage. You're looking at your venous drainage. Okay. It's oscillating between minus 150 and minus 250. So what do you do? What are the first things you want to do potentially? And
see the sides.
Hmm?
See the venous side.
What do you mean by seeing the venous side?
Maybe something like something kicking on the side.
So as we said before, you're always going to do 2 things. Assess your patient, assess your circuit. And you want to assess the circuit from beginning to the end. Because sometimes it's very easy, you have just moved the patient, there's a little bit of a kink. But if it's a kink, usually it doesn't give you chatter. It just gives you the flows are dropping, but not necessarily chatter. But we've looked at the circuit is fine. What are the other things that you want to look at?
Maybe the patient is a bit maybe agitated, intrathoracic pressure or high abdominal pressure.
Okay.
Squeezing the cannula, or maybe the cannula is hitting the wall something.
Yeah, so it could be a cannula problem. either position or intravascular depletion from your patient or increase intraabdominal pressure. What else can you do?
Low volume.
Low feeling pressure. So, but when you have chatter, what is the first thing that potentially you want to do? Even before that, because even the fluids, you're going to take the fluid, you need to be spiked in the bag, you still have like 1 minute. So what is the first thing that you potentially can do?
Decrease the speed.
Yeah, you may want to decrease your rotation per minute, because what happens with the chattering is you have your vessel, you have your cannula, and the vessel is being suctioned on the cannula. So sometimes it's a bit counterintuitive, but you may want to decrease your RPM to allow the vessel to fill up again, and then maybe that's all you have to do, right? Maybe with lower flows, the vision is still supported, and you don't need to do fluids, and you may just want to stop your diuresis or whatever. Sometimes it's not enough, and in those cases, you want to give the fluids. Let's say we've given a liter of fluids, and this is still happening. What else?
Chest X-ray during a COVID.
So what are you looking for?
Chest X-ray, if there's pneumothorax, so something that would increase the intrathoracic pressure
Yes,
and echo for Kaplan.
that's right. So you have it all, but you always want to do those things. Because sometimes drainage insufficiency, the patient's going to receive 5 liters of fluid, and then in the morning you realize that he was a tension pneumothorax. So it's very happened to all of us, but uncommon. So once you've checked your circuit, you want to look at the cannula position. The first one you can see, the IVC that should be here is almost gone. So probably the patient is either intravascular dry or they're bleeding somewhere. Always possible, patients are anticoagulated. Could be a cannula position issue, as you can see. This is the left atrium, this is the right atrium. You see the tip of the cannula is stuck in the interatrial septum. Every time the patient's coughing, your will gets you flow. In those cases, you may have to readjust. Could be a pneumothorax. Either you do a lung ultrasound, as you can see here, there's a lung point just right there. You see the sliding that stops just here. On an X-ray, corresponds to that. As I said, always uncomfortable to give 5 liters of fluids for someone with attention. Very nice X-ray. Yeah, should not happen, but it did. And you want to make sure that it's not pericardial infusion. The same thing, you will give fluid. At some point, it could be that if you have increased pericardial pressure, the fluid is not going to be in. And it could also be fungus in the cannula, could usually, again, doesn't cause chattering or decreasing flows, but all the things that you want to check, circuit, patient, and then uresis. Okay. Let's say that in the case of our patient, it was just that the patient was intravascular dry. We reduced a little bit the RPMs, we gave a little bit of fluids, everything is okay. Now, the following day, we're still on the same ventilatory settings. The FiO2 now stayed at 0.8, but the saturation is now 100%. And the patient is intermittently losing pulsatility of the arterial line tracing. You do blood gas from the right radial artery. The pH is 7.48, PCO2 is 22, PO2 is 280, lactate is 2, and your ECMO flows are 4.5, rotations per minute 2800, the LTP is not changed, 24, FDU is 1, so gas is 2. What are your thoughts? Just in case you know them, those are the pre and post membrane blood gases and the ECMO flow. So pH is the pre is 7.45, PCO2 is 25, PO2 is 40, saturation is 70%, post membrane. PO2, which is the most important variable, is 354. No, it's 40. I mean, it's 25 on the other one, yes. The patient's still breathing. Remember, your oxygenation and CO2 clearance is always dependent on both patients. and ECMO. On via ECMO, presumably if your lungs are okay, you may be having someone who's hypercapnic. So we have someone who has decreased pulsatility, even losses of pulsatility on the ECMO, and flows of 4.5. So what is your next step? What is the first question you want to ask?
Is it the fault of the ECMO?
Or is it the fault of the patient? Or both? So the first question is it true that the aortic valve is opening or not opening? That's the first question. The arc lines not working should be really the exclusion diagnosis. The first question is the aortic valve opening? The only way to know that, if your arc line is not giving you a number, is to look at an echo, right? So that's what we did, and this is what we saw. This is still a transesophageal echo, left atrium, left ventricle, aorta. And then you have the X-ray on day 1 and the X-ray on day 4. So what is the problem?
What do you want to say?
Would you want to have this heart? I don't. Don't want to see that. So two things. Lots of bubbles in the heart, right? Those are bubbles. The aortic valve is barely open. So we have a problem. We have a problem that is probably due to the fact that we have increased left ventricular diastolic pressure and increased left atrial pressure. So as we said, via ECMO, peripheral via ECMO, you're infusing in the opposite direction, which allows perfusion of your organs. The problem is this is increasing the afterload of your left ventricle. A normal left ventricle is probably capable of ejecting against this increased afterload. But if you put your patient on via ECMO, presumably it's because the heart contractility was decreased, and as much as you're perfusing your organs, you're impeding the ejection, the native ejection, and this heart is no longer able to generate the pressure to open the aorta. And the more you increase your echo flows, the more you'll see that your diastolic pressure will increase, and with that, you can also see that your stroke volume is decreasing. So you may reach a point where you have very high end-diastolic pressure, the ventricle becomes distended. Because it's distended, it can no longer eject, and it's a vicious cycle. So that can have some consequences with increased left atrial pressure, which will have an increase in your pulmonary edema, so your vision may start desaturating. But that's only if there's still ejection. In the case I showed you, the valve's not even opening. That's why when you did the blood gas, the PO2 was perfect. But unfortunately, your heart is suffering because of the increase of the end-diastolic pressure. What are the consequences of having an aortic valve that is not opening? Yeah, you can have first increased LF pressure, but you can also have clots in your left ventricle. You can have clots in your aortic root, which is something that we want to avoid as much as possible. You can also have pulmonary hemorrhage because you have increased capillary pressure and increased pulmonary pressure. So you want to avoid that as much as possible. So how do you approach this? What are the first things to do? And sorry, you also by increasing the left ventricular and diastolic pressure, you also cause some endocardial ischemia. So you put your patient on ECMO potentially to help the circulation, but if you have ongoing ischemia, that will potentially impair the heart. So let's say you're in that situation, aortic valve is not opening, what do you do?
Decrease the flow.
First thing is to decrease the flow. How low? How low do you go? 0.5, 1, 1.5.
5%.
I guess it depends on what you're starting with. I would say there's no rule, but if your patient is anticoagulated, probably 2 liters is safe. If you start going lower than it is for a prolonged period of time, you will have to do something else. You want to use the lowest flow possible to maintain perfusion, but also to maintain the patency of your circuit. Because if your circuit clots, then you don't have any support anymore. So I would not say it's written in stone, but probably 2 liters and above you're okay. Anything below that, you'll need to consider other strategies, knowing that again, if your patient needs to have 3 liters and they're not perfusing in 2 liters, then you need to do something else. So they're reducing the flow, right?
Is there anything, would you be able to titrate it based on echo? So decrease the flow based on the...
Yeah, if you want to decrease the flow, you can look at the aortic valve opening. It's instantaneous. As soon as you decrease the flow, if your heart is still able to generate some forward flow, you will see the valve opening, and then you can titrate into that valve. Yes, you can add some inotrope. Obviously, you don't want to be at the same doses as you started with, because that will also impair your oxygen, your myocardial oxygen consumption. But you may want to have a little bit of inotropy on board to allow a little bit of forward. Yes. Oh, if I do. No. I'm not aware of any study that's saying that one is better than the other. The real question is, can you even recruit some contractility? The patient you showed earlier with the myocarditis, you can give them all the inotropes you want. At the very early phases, there's nothing. The heart is just tense. And in those cases, you may have to consider other things or just wait. So, but I'm not aware of any inotrope that is better than that. You use weight.
Are you making?
Before that.
We can use
Easier to than augmented.
IABP or something.
Before that. No, before that. Before all that. So, we decrease the afterload by decreasing the flow. We try to recruit some contractility. What else does a heart that is distended potentially need? Very easy stuff.
Train the organ.
Huh?
I'm just thinking, train the use of freedom.
Yes. Good all basics,
Yes, there is.
right? You want to decrease your, is it that?
Lasix infusion. Lasix.
Some diuretics. And then, if all of these fails, then you may consider the vent. So we went there for this patient. And then it's all the situations that you discussed. How to vent the ventricle. So, those who work in the ECMO center, I'm curious to know, what do you actually use in your center? What do you have available? Where is your go-to?
I think everybody has.
What do you use?
First easier thing is the balloon pump. It's easy, just 16 French scale or introduce. In ischemic heart disease, they put the cath lab implant. So in the ECP, if the patient is ECPR, it is easier for them when they are cathing the patient's coronaries to put the implant. Because we know the ECPR, we need to. Septostomy is in patients who are, so mostly they are medical myocarditis who get septostomy. That's what we use.
And the others who work in ECMO centers, what do you use?
Balloon pump.
That one is quite easy.
If you do prophylactically, or do you see what happens?
So, depending on where you work, I'll tell you. Some people will say everybody should be vented. And then you go to one center, they say balloon pump for everyone. You go to another center, it's impeller for everyone. The reality is, no one knows if you should do it preemptively or just wait. Some patients never need to be vented. And venting it's not innocuous, right? There's, yes, the balloon pump is easy enough, but it still comes with complication. The problem is in the literature right now, you have a lot of retrospective studies that tell you this is what we do, it works, it's great, everybody should do that, but it's confounded by the fact that you have a doctor deciding when to vent and when not to vent. There are ongoing randomized control trials that may or may not give us an answer, but at the present time, I don't think there's evidence to say you should use one route or the other. But, and I'll just go there, I think this paper here, for example, looked at IVP on via ECMO versus Noventin. They said it favors IVP. They also looked at versus Impella, but again, it's all retrospective. So if you're a center that does a lot of Impella and you're used to it, you probably have better outcomes than if you never do it. To her point, Impella alone showed that it decreases the size of the ischemic myocardium. So potentially, there's some thinking about using Impella in the setting of ischemic disease. But again, that's not necessarily in the setting of VA ECMO, and that's for a specific indication. So I guess we don't really have the answer. But there are some situations where you won't be able to use one venting strategy, and I think that's more important to understand rather than deciding what you're going to do. So what are situations where there's one of those that we mentioned, IABP, Impella, septostomy, that you will not be able to use that? Let's start with the IABP. Contraindication to use an intra-aortic balloon. Yes, if you have more than mild aortic regurgitation, you will increase that regurgitation by putting your patient on an intra-aortic balloon pump. So then it defeats the purpose of what you're trying to do. You're trying to offload the ventricle, but you increase the outflow during diastole, which is what the balloon does, but then your regurgitation is going to get worse, and then you will have all that blood going back into the ventricle. So in those cases, the intra-aortic balloon pump is not a good option. Any other contraindications with balloon? Yes. Although, hopefully you didn't put your patient on via ECMO for aortic dissection, or you caused the dissection. It's always possible, but you're right that if you have an aortic dissection, you don't want to put an intra-aortic balloon pump.
Maybe post-operative after steroid release.
Yes. So, what about the Impella? Just maybe I'll come back. Everybody knows what an Impella is? Maybe not. So the Impella, it's a micro-axial pump. You have cannula that comes usually from the femoral. You can put it from other places. But you can see you have, depending on the size, you have a pigtail here. You have an inlet where the blood is going there, and an outlet. And the outlet should be above the aortic valve. So you drain and vent the blood directly from the left ventricle, and it infuses it in the ascending aorta. So what do you think some contraindication to an Impella could be?
Thrombus, example.
Yeah, because if you have a thrombus, you're going to nicely drain that little clot, make a little bit of mush out of it, and then infuse in the ascending aorta. You don't want to do that. So if you have an aortic thrombus, you don't want to place an Impella. What else?
Mechanical valve.
If you have a mechanical valve, you probably won't be able to insert it. Yeah. Similar to the IABP, if you have a more than mild aortic regurgitation, you will also increase the pressure in your aorta, so then you have a closed loop. So if you have more than mild aortic insufficiency, you don't want to place an Impella. Last one. some people have face patients with that condition on an impella. But if you have a ventricular septal defect, let's say your patient is post MI with an ischemic VSD, if you have an impella, potentially you will create a right to left shunt. It's been described that some people have temporized with an impella, but theoretically you want to avoid because you will drain some deoxygenated blood and it will infuse in the aorta. That being said, since I'm already on that slide, some people will advocate that the impella is good because it does a direct venting from the left ventricle. You can titrate how much flow we have. Potentially, if your patient's on an impella and a VA ECMO, you could win the VA ECMO, leave the patient on an impella, and then win the impella. The downside, though, is that it needs to be very well positioned for it to work, otherwise you have lots of hemolysis. And the position, you can do your x-rays and everything, but you need an echo, because you want to know exactly where the cannula is in the heart. So you can see here, this is the inlet that you have there. The aortic valve is here, and then the cannula is in the same area. I'll go back to this slide. Just to summarize, so impella, every thrombus you want to avoid. If you have more than mild aortic regurgitation, you also want to avoid ventricular septal defect. Same thing, IVP we mentioned, and you'll need an echo to monitor and place all of those. Just to talk about the downside of IVP. This is not a patient, but this is another patient, where you can see blood pressure is 93/56. Patient is on no vasopressor, no inotropes. The ECMO flows are already quite low, 2.2. Patient had an MI and already had a balloon in place, which is at 1 to 1. And pressure control of 10, peak of 10, FiO2 2.5. So this is a transthoracic echo. You can see left ventricle, left atrium, aorta, right ventricle, left ventricle, left atrium, right atrium, right ventricle. So what is the problem?
The aortic valve is still not
Hmm?
The aortic valve is still not open.
The aortic valve is still not opening, but the blood pressure says 93/56. Yes. So that's one of the tricks with the balloon, especially if it's on 1 to 1. Intermittently, you want to pause your balloon or decrease the frequency to make sure that the valve is actually open. Because in that case, it looks like the blood pressure was perfect, but the valve was actually not open. So what we did was we started a little bit of inotropes and nitroprusside, and for which we had to increase the flow because then the map was really low. And with that, the valve started to open. The septostomy, so in that case, you add another drainage cannula that you make a hole through the septum and you drain from the left atrium. That should decrease your left atrial pressure first and then your left ventricular and diastolic pressure. If your heart can still eject, it should allow to have some reopening of the aorta. The problem is, number one, it's not a direct LV venting. It's very difficult to titrate the flows. You will need a partial clamp and decide how much comes from the septostomy versus what's coming from the main drainage cannula. And depending on the situation, the fact that you're draining some blood from the left atrium may actually decrease some of the forward flow that should go through the LVOT and help opening the aortic valve. So sometimes you put your septostomy and you still have no opening of the aortic valve. You're draining, but you're still not going to have an opening of the valve. And if the flows are too low, it can also cause some thrombosis. And if you look at an echo, same thing, you see that cannula that is through the septum. This one is on purpose, and you see the drainage cannula is crossing here with the one through the septum. But you see that in that case, it's still not working really well because you still have some significant companion cycle contrast in the level. We talked about that already. And then you can directly vent your ventricle. If you have a patient who was a surgical patient, you can put either directly in the apex or in the pulmonary veins to drain the ventricle, but that's only if you have already suppressed. And the goal is, number one, to restore some contractility, to have a pulse pressure that is, the paper says 10. I don't know how they came up with 10, but that's what they said. Know that, as I said, if you have a patient that has at the acute phase of the myocarditis, you won't have any ejection for 2 days. And then 2 days after, the heart will start recovering. So most of those patients in my center will probably wouldn't vent because we know they just need 2 days of nothing happening and then the flow will restart. Any questions so far?
Can you go over how the doing the cyclostomy helps open up the aortic valve?
It's all by decreasing your left ventricular and diastolic pressure. If your ventricle is that distended and your sarcomeres are too far from each other, there's no contraction. So the goal is to decrease basically the preload of your ventricle to allow more ejection. But it's not a direct venting. That's the argument for some people to say we're not going to use a cyclostomy. So we saw earlier one option. The aortic valve is not opening because the flow is too high, the afterload is too high. What is the other possibility why the valve may not be open? Kind of alluded to it before, but it's important to keep in mind because lack of aortic valve opening doesn't always mean venting.
Thrombosis.
Yeah, that's when you're waiting for too long, yes.
Aortic valve insufficiency.
The valve should still open.
Cirrhosis or
The valve should still open.
MR.
Why would the MR not cause the valve to open? Because you have flow going back and forth, right? So it should still be going forward. Something that you can relate to drainage insufficiency. We talked about it earlier. Yes. So if you have increased intrapericardial or intrathoracic pressure, or your patient is extremely hypovolemic, the valve may not open just because of those reasons. So again, we want to do the same systematic steps so that you don't go and vent someone who's in tamponade, because that's, again, also uncomfortable. So in that case, you see that there is a diffusion there, and that is quite circumferential. On its own, you cannot say anything, because this could just be because your patients are like more strained, but you want to see the evolution. If you had no effusion the day before, and now you have this effusion and the valve is not opening, that could be the reason why the patient is not having ejection, and in that case, rather than putting an IABP or Impera, you want to drain the effusion first and see what happens. Since we're on the topic, how do you know if someone is on ECMO, and in that case more VA ECMO, how do you know the patient's in tamponade? What are the signs? How frequent is that? That they are hypotensive. When you're on VA ECMO, what are the first things that you may see if your patient is in tamponade? So we have heart rate, hypotension, reduction in the venous drainage insufficiency, yes. Radical.
flow not maintained? Flow will not maintain.
Mhm.
We will give fluid on repeat, but it's not
Mhm.
coming
Yes.
back.
So the reason why you don't know is because it can present with nothing. Meaning you can have none of the signs that you would expect. Depends on how much flow in the circuit. So you may have the drainage insufficiency with your flows that are going to be decreasing, but sometimes you don't. One of the last patients that I saw that was on VA ECMO, flows were steady, lactate was normal, everything was normal, vision peeling. The heart just stopped ejecting, and it stopped ejecting because the intraperitoneal pressure was so high that it compressed the coronary, so there was some sort of myocardial ischemia. But otherwise, none of the signs were there. So besides doing serial echoes, I don't know what other signs are typing out on the echo. That's what I'm trying to say. So be very vigilant with that. Sometimes I hear people saying, "Oh, the flows are not dropping, so it can't be tamponade." That's not correct. Sometimes the flows are not going to drop. Or they'll drop, you give a bit of flows, and then that settles, and that's it. So you make sure that at some point you do an echo to make sure that you don't have an increase in your size of the pericardium.
How did you detect the tamponade in that patient? You just do an echo repeat?
We were doing serial echoes, and you could see it was increasing in size as we were doing the echoes, and then one day the pulsatility was gone. So it was more on the evolution rather than on the one time point. Had a lot of struggles convincing the surgeon to do something because the patient had a thoracotomy. But eventually, as soon as they drained, then the contractility was restored. So sometimes it's not, you won't be able to say it one time. You just need to follow. And if you're on VA ECMO, presumably, if your flows are maintained, you're still perfusing. But the two organs that are not perfused is your heart and your lungs. So you just want to be doing serial echo. So, let's go back to our patient. Now, you've done all of those things, the pulse pressure restored at 20. The FiO2 point, it was still 0.8. My mistake, the saturation is no longer 100, the saturation is now 80%. So you have a patient's blood gas that is 7.48, PCO2 22, PO2 is 48, and saturation 80%. ECMO flow is 3.5. Delta P 21 and DO2 1. And you've just checked your pulse membrane PO2, it's fine. So what now?
Echo.
What is the question for the echo? There's no tamponade, and the valve is opening. It's opening and you have 20 of pulse pressure, so.
Maybe we need to increase the flow.
So what would the increase in flow do for this patient? It may fix your issue, because your most acute issue is you have some hypoxemia on the right area. So increasing the flow may be able to move that mixing cloud up to the aorta, but then that will increase your afterload, and then cause LV distension, and then we're back at the situation before when the valve may not be opening. So what is the other thing that you can think of in those cases?
We'll take a sample from left radial.
From the left radial, if you had a left radial, 7.48, 22, 205, 100%.
Is the SpO2 monitor also on the left side?
They put some monitors everywhere. Yeah, it could have been. That's why. Yes.
There's a difference.
Yes.
There should be some mixing or shunting.
Do it separately.
Harlequin, maybe?
Yes. So they used to call it Harlequin, north-south. It's not, it's a bit of a misnomer. So Harlequin is it's a character with many colors. But north-south is not always accurate, because in this case it was east-west, right? The right side was oxygenated, the left side wasn't. So you never know where that mixing cloud will occur, because again, it depends on how much you're flowing and how much your heart can inject. To be able to have dual circulation, you need to have an ejecting heart. If your heart's not ejecting, all the blood that is infused in the aorta will go out to your coronary artery, so you'll have a saturation that is very high, but again, risk of distension. So for this dual circulation to be possible, you need to have some ejection. But the north-south, east-west, it's better to talk about dual circulation or differential oxygenation, and differential hypoxemia is also not correct, because all of this is hyperoxic, if anything, and this one is hypoxemic. The differential oxygenation is better. So, what are the possibilities in this patient? Could be what we talked about before. You have some degree of pulmonary edema, but it could also be that your patient has a pneumonia, right? So this one is pulmonary edema, as you can see. But this one, if your patient now has, for whatever reason, they aspirated, they have pneumonia or something like this, venting is not going to help this patient, right? Because you can vent all you want. This lung, with this heart that is ejecting a little bit, will eject some deoxygenated blood, and you will have that mixing of the circulation. So when you have dual circulation, you always want to understand, is it because of increased ventricular pressure, or is it because you have a new pulmonary pathology? Otherwise, you'll vent someone with a pneumonia, which unfortunately is not going to work. And if you have an X-ray like this one, probably you would want to switch to a hybrid configuration if your patient's not ready to be decannulated from via ECMO. And so you will, as Alia mentioned, have your oxygenated blood going both in the venous circulation and in the arterial circulation to be able to support both. Does that make sense? So when you have a differential gas exchange, first you want to check, is it a problem of pulmonary edema, is it a problem of pulmonary process? If it's an increased left atrial pressure, you first do your decreasing the flow as low as possible, as long as you maintain your perfusion, diuresis, inotropy. If that's not enough, then you move to venting strategies. And if it's a pulmonary process, you want to optimize your ventilatory settings, because maybe that's all you need. And if that's not enough, you may need a hybrid configuration. Any question on this? No? Okay, so let's continue with our case. Back to our first patient. It's kind of doing a little bit better. And now we're going to assess if they are ready to be decannulated. So they're doing an echo. That's what you see here. We're at 2.4 of the echo flow at the beginning. We go as low as 0.7. And with this, they measure the mitral annulus at 7 centimeters, tricuspid S prime 9 centimeters, the TAPS is 12.5, and they did the left ventricular outflow tract velocity time interval, that is 13 centimeters. And then also the ejection fraction is 40%. And also some fancy measurements with the strain of the heart. So let's do a show of hands. Who thinks the patient's ready to be decannulated? Patient's not ready. You need more information. You cannot say based on this info, you're out of office.
So you think he's ready, based on which parameter?
Injection fraction, VT,
Okay? Anything else you want to know?
flows.
Hmm?
ECMO flows.
They were 0.7 at the lowest. Anything else?
The numbers look, I don't want to say it's different, but the numbers look good, that unless I missed that the epinephrine dose seemed higher than what I would like.
Yeah.
Yes. You want to know more. Because just looking at the ECMO flows, if to achieve those numbers, you need to be on 0.5 of epinephrine, you're not ready, right? So, yes, the echo is crucial. You will need an echo, but you want to look at how your patient is doing, the blood pressure is maintaining, how much pressors and inotropes you need, and if the patient is okay and your intake and your perfusion and all of this. Because again, if you need 0.5 of epinephrine, Miranon 0.75, or whatever inotrope that you use to maintain those numbers, then the patient's not quite ready and you'll need to reassess. So when you want to win your patient, it's really a multifaceted approach. Yes, you will need an echo, but you want to look at all the rest. Otherwise, you'll think the patient's ready, you'll get them to the operating room, and you'll sedate them, and then you realize they were not quite ready. So you really want to integrate all of this in addition to your echo parameters. And some centers have a very detailed protocol. Supposedly in my institution we do have a protocol, but I'm yet to see it in practice, just putting it out there. For the echo parameters, the ones that have been initially described is your VTI, which basically tells you your cardiac output should be more than 10 centimeters. The ejection fraction should be at least 20%, and the tissue Doppler velocity at the microannulus at least 6 centimeters per second. But also you don't want to forget about the right ventricle. Somehow it matters. So if you have worsening ventricular interdependence, it may also mean that your patient is not ready. It's extremely difficult to assess the right ventricle when you're on ECMO, via ECMO, because even 1 liter of decreased preload to the right ventricle can be enough to make it look like it's working fine. So you want to integrate all of this. If you have access to 3D right ventricular ejection fraction, a number above 25% is the way to go. And then there are also parameters to look not only at your pulmonary pressures, but also at the coupling between your right ventricle and the pulmonary pressures. Because again, having hypertension, pulmonary hypertension, if your ventricle is still capable of generating that, that's fine. But when you have a low peer pressure, it doesn't tell you if it's low because it's normal, or if it's low because the right ventricle cannot generate the pressure anymore. So you may use some markers to be able to help you differentiate those. And also looking at dynamic parameters, meaning how those variables change when you decrease the ECMO flows, is also a better marker than just looking at one off marker. And this is just to summarize what I was just saying. Your echo parameters, but you also want to look at the patient, look at how much inotropic support you need to make sure that you're not saying that the patient is ready while they're not quite ready. Okay, done just on time. 5 over. Any questions? No? It's all clear as mud.
Did you guys enjoy it? Did you find it? We tried to tailor it to get, like, infuse some of the advanced and target some of the basics, and a lot of arrays. And hopefully when you read, no one read the objectives of the agenda, right? I hope. Because I thought that would give away what we talked about. But how would you rate it? Do you have
It's not fair to ask them that in front of them.
No. I
They
already
are
have
pressured.
No, do you guys feel that?
12 out of 10.
So you have an online, I think they emailed you for the evaluation. So we hope to, if you guys could use that, because that will encourage more and more workshops. I believe ECMO is more of a discussion and sharing. This, I don't think ECMO can be read off a book.
No, I mean, you can read some stuff in the book.
Yes.
It's good to read some
It's
stuff,
great,
but then
but-
the patients, they don't read the books.
And there is
But
not
in one, I
enough,
don't.
not enough evidence to lead you in everything. Nothing. We're still on ECMO. It's not, we're not like cardiology. Everything is evidence-based because they have so much of a patient pool to do study with. Any questions for me, Patrick, Ghislaine?
We'll be here for the rest of the congress anyway.
Yes.
If you're too shy to ask me questions, you can find us.
I just want one question from,
Yes.
I would like to bring it up. Is it preferable to use a bi-cable for a drainage cannula or a multi-port drainage?
I would say it, as we said, it depends.
Yes.
We use only the multi-stage, but when the patient is central cannulation, they will have a bi-cable. We don't use the bi-cable with the peripheral, but you were mentioning several times
Yeah.
that sometimes you
So
use
do
it.
you mean the bi-cable that is Medtronic where you have few holes and nothing to hold? So it depends, are you doing VA or VV? Because if you're doing, if you're doing a VV, it's better to use the multi-stage as a drainage and the arterial as return. Because if you use the bi-cable and you push to the SBC, the drainage hole of the SBC will be exactly against. But in Saudi, we had some shortage of the multi-stage. So we did use the dual stage, but we put it down in the tip barely in the right atrium. So it didn't really function as a dual stage. And in the short patient, we went through the left side to give us some length. That was during the shortest time. In the central echo, you have to use the bi-cable because you want to drain as much as possible from the venous return. Also, in the peripheral VA, you can use the dual cannula. But mind you, it's quite long. It's 76 centimeters. It's too long. But it's good for the VAs. But don't drain the whole venous return. Then there will be nothing to flow in the heart, and your aortic valve will be closed, and then you will clot. It's very, I think if you have an ECMO card where you guys put your stuff, it's very good to have some reference for the cannulas and the flows and the calculation for the flows. Because most of the people who will insert ECMO will ask you what flow we can get and so forth if they measure the vasculature. Because some small patients like Chinese or Eastern, you're challenged with especially the femoral vein. And the multi-stage or the dual stage, the last hole is barely 32 centimeters. So the patient is not tall enough for all those holes to stay in. You might have one slipping out easily. Thank you so much for staying with us. Thank you.